sort of give a couple of introductory remarks about why we're here. First of all, for members of the committee, because of the coronavirus and the situation in which we find ourselves, there's been an awful lot of stuff done without committee meetings and opportunities for the committee to participate and all of that, and I regret that, but one just does the best one can. But one of the purposes for meeting today is to get us all up to speed on where things stand with the legislation that we've passed. I see that there's some people in the room who are not lawyers, and I will let you in on a secret of the practice of law, which is known as forms. And if you go to a lawyer to write a will, a lawyer is going to have a book of forms or maybe some old forms that he or she has used. And so although the will be adapted for whatever you want, the lawyer does not create this will out of whole cloth. I would say, just as an aside, the proper selection of the forms and adapting them for your purpose is a very fine and difficult thing to do. And on behalf of the financial interest of the profession, please write your own wills. There's so much more money made in straightening them out than there ever is to be made in just writing one.
Mr. Chairman, please don't give away our secrets. Us lawyers, we have to keep something to ourselves.
I know. But I mention that because of what we're dealing with the legislation we're talking about. There ain't no forms for this stuff. We've had to draft legislation, and yes, we're here to talk about an appropriation bill, but it's not like any other appropriation bill. You can't go find last year's appropriation bill and sort of use that as a starting point. It's made up out of whole cloth. The people that are administering these programs are administering programs unlike what they normally do. This is all different. There ain't no forms. This is all made up from scratch. So everybody involved in this has my sympathy. And the purpose of our getting together is certainly not to beat up on anybody or complain. I knew, and I think any thinking person would know, in all of this operation we're going to make mistakes, and all of us are going to make mistakes, and there are going to be issues. What we're here for today specifically is this. We have a 2-day session, and only a 2-day session, coming up in about 10 days. It is possible, if there is a consensus in advance of that session, that we can pass legislation modifying what we passed before or making changes if there's a desire to do it. The purpose of our being here today is to find out how things are going, what problems have come up, and on and on. So what I've done is I've sort of arranged things in terms of the agencies that were responsible for various parts of the bill. And our first presentation is from the Department of Health, and I've asked Greg Michel from MEMA to come because there are some questions about MEMA, but I have very good news for everyone about Mr. Michel's presentation. He called me earlier today in response to a call I made, and the first word out of his mouth was representative. So looking on the bright side of things, which I intend to do, as I've explained to him, there is only one way to go from that beginning. So we're on an upward path already. Dr. Dobson, before getting into specifics, it appears you have some material for us, so why don't you just go from here? And we'll try to get you and Mr. Michel out of here in time for your appearance on As the World Turns.
No, thank you so much, Senator, for having us, and I'm going to try to keep it short and sweet, pretty straightforward. We received $83.9 million to distribute from the CARES Relief Fund, And you can see the different distributions: 80 million to healthcare facilities, 1 million to rural hospitals, 1.5 million to community health centers, 1 million for McGee General, 250,000 for Access Family Health. And you can see thus far we've expended 91.1% of that money. On the rural hospitals, we are in process of getting that money processed, but we have every anticipation that before the end of the month we should have all the money out the door. I do think it's important to talk a little bit about the process, just so you're aware, and you can ask additional questions. The method of distribution was consistent with the language in House Bill 1782. We have a signed attestation with guidelines for submitting monthly reports, but we did sub-grant agreements with advance payments so they could put the money to use, but they have to submit ongoing allocations to make sure they meet the requirements of the CARES Act. We do think that a lot of them are actually will meet the requirements on previously encumbered expenditures, so that it really should be almost like a one-time submission. We get monthly reports to support with documentation. All funds must be expended according to guidance from the CARES Act, and Harper Raines Knight and Company CPAs are reviewing submissions for every single receipt or documentation to assure that the money that's being expended is consistent with the language in the Federal CARES Act. We did have a determination of the amount for each of these different facilities. For the healthcare facilities, for the acute care community hospitals that were taking care of people who were sick with coronavirus, we did as directed by the legislature. Rural hospitals, again, in the language of the bill. Community health centers was according to the Mississippi Qualified Health Center distribution formula that we do for the normal distributions from the state. So that's why there's just a little bit of variability in there, but it's relatively, relatively close. And then certainly for McGee General and Access Family, we did the amounts based on what was in the bill, and that's basically it. But we should have everything expended. I would think within a month. Jim, you think by the end of the month we should have it all out the door?
So, from your perspective, as far as getting the money in the legislation out to where it was sent, you don't see any major problems with that?
No, sir. No, sir. The details of the accounting are going to be the most important thing, but we feel comfortable with the firm that's handling that component.
Regarding the $80 million in health care to hospitals, it's my understanding that money went to critical care hospitals and it did not go to rehabilitation hospitals or psychiatric hospitals.
Yes, sir.
It's my understanding that the department, at least initially, made a decision that although there were needs at psychiatric hospitals and rehabilitation hospitals, the more critical needs were at critical care hospitals. But I've been contacted, I'm sure you've been contacted, and others have, and I've got stuff I'll distribute later about their needs and the expenses they have incurred. And clearly, these other facilities have incurred expenses. And so one of the issues is, if you're keeping up at home, whether we wish to add funds for other hospitals, including Methodist rehab, psychiatric hospitals, on and on. So that's just one of the issues that we might want to consider. Secondly, as regards the hospital in Senatobia. As the bill now reads, that $2 million will be reallocated to hospitals, assuming that it's not used in Senatobia, which would produce another $2 million for hospitals.
Well, our understanding was we were not going to reallocate that money to the other hospitals, but we certainly, will do what we need to do.
Well, the bill itself provides for that.
Oh, does it?
Yes, the bill itself says that if the Senatobia Hospital project is not far enough along or whatever by a specific date, then the $2 million would be reallocated to hospitals. So I'm assuming that it's a relatively simple thing for you to send an additional 2.5% or whatever it be to each hospital.
Yes, sir, that should not be a big issue.
There also is the question of the $6 million to the operation that the community, the regional health centers had, rural health centers, primarily in the Jackson area. That $6 million was subject to an attempted veto by the governor, and there's litigation about that. But the dilemma that presents itself is what happens if that litigation is not complete by December 30th. And I'm thinking that $6 million then just is not used. So the question that presents itself is, do we wish to make some alternative allocation for that $6 million if there hasn't been a resolution about it in December? And I don't so much expect you to have an opinion about that, as to say if we're making a list of things to be concerned about, that's one possibility. In other words, you could have a provision that says if there's not a resolution of this matter by the state Supreme Court, or the matter's still pending, or it's in the courts or whatever, on December 15th, something else would be done with the $6 million. So, I mean, that is a possibility. Are there questions for the Department of Health? Dr. Dobbs? If not, thank you.
Thanks, sir.
And Mr. Michel, while you and Dr. Dobbs are still here, I personally keep getting confused in my mind about what personal protective equipment MEMA has, including testing and all of this stuff, how it's being sent, where it goes, whether it's free, and whether you've got enough of the stuff, and whether you've got money to get it, all of that. Could you just generally explain to us how that works?
Yes, sure, I will. Thank you, Senator. So,
Better, much better.
yeah,
You're already
and I
doing it.
apologize about that
Already
earlier
doing
today. I truly did think that I was returning a call from a representative. Had I known it was you, I would have addressed you more properly, so I apologize about that. Nothing against representatives at all, but so, Senator, where we are today on PPE, we're in a far better place than we were when we started this. And as Dr. Dobbs can attest, we spent a lot of late nights worrying about figuring out how we were going to get PPE. And the problem began because Mississippi was not a recipient of, to a large degree, the national stockpile. And that was based on allocations that other hot spots across the nation. So we were, however, given as much support as we could get. And through acquisitions, we were able to get PPE. To your first point, though, where is the PPE going to? We identified, in working with the Mississippi Department of Health, a number of tiers, and I'm doing this from memory. It was approximately 5 different tiers of support. And to be quite honest, in very early efforts of this, the only people that we had PPE that we could send to were those Tier 1 facilities that were direct engaged in treating COVID patients at the time. As our stockpile of PPE began to grow, which was some 30 days later, then we were able to expand that to include emergency management personnel. And then as it expanded from there, then we were able to address more of the healthcare needs. But there was not enough PPE to go around to even address the first 2 tiers, much less all 5 tiers at that time. And I don't have the tiers in front of me. I apologize, and we can talk through that. But in much the case, some of the entities you've already identified here would be those healthcare facilities or clinics that were treating COVID positive patients, and then long-term care facilities or nursing homes that were treating COVID patients were recipients of the PPE to also include emergency management personnel, which would be your first responders, your police, your fire, your AMR, because those were the ones that were in a lot of cases transporting and handling COVID positive patients and getting them to those facilities. So that's how the PPE was allocated. Today, I'm very happy to report that today, and our goal was, as we moved along, was to be able to get enough PPE to have a stockpile in place should the fall spike occur. And I'm looking at Dr. Dobbs, and I'm hoping that that does not occur, but the statistics would show that we probably will see another spike. But if we do, across the board, we've got approximately a 60-day supply of PPE now that we've got going into that fall. And according to the public assistance and the FEMA guidance, we're able to roll into and out of this emergency a 60-day supply, which will continue to be eligible for public assistance reimbursement. So that's how we've been managing the PPE.
Well, let me interrupt and ask, what is a 60-day supply for? In other words, who is it that would receive that 60-day supply? Because obviously there's some people that are not going to get the...
Well, that 60-day supply would be for the tiers, but I will tell you that those tiers can be modified, and if those tiers are modified and it's constantly evaluated as to where the needs are, then we'll support that. But the 60 days of supply, we base that off of usage that we have had throughout this pandemic, and there's two models out there. CDC, FEMA has a model out that's pretty robust. We use an actual guidance based off of the PPE burn that we've used throughout this event. And based on that, we've got 60 days, and in some cases, we've got a little more than that on some of our items. But those items would not necessarily have to be strictly relegated to those tiers that we have right now. We do reserve the right to modify those tiers if the demand or if the priority has shifted any.
Well, I don't mean to interrupt, but I keep getting confused by this discussion of tiers, because you might as well say there's an infinite demand for this stuff. There's everybody everywhere needs it, apparently including state legislators. And so I'm assuming you're not providing it to everybody everywhere. I also assume that given, at this point, given infinite resources, people could purchase the stuff. But the dilemma is there are people out there who can obtain the equipment, but only at great expense. And I'm assuming that when y'all distribute it, it's free of charge. Is that correct?
Well, I mean, we are providing it to those facilities with no expectation of reimbursement. Yes, sir.
Yeah. So, I mean, it's sort of a dilemma. And I mean, some of the people you're providing it to are also purchasing it simultaneously on their own, I'm assuming.
Well, and we do get reports from FEMA on our national suppliers that are directed, and we get that. So, yes, there are entities out there that have been buying it, and I'm glad that they have, because it's taken pressure off of us throughout the process. But that is a true statement, yes, sir.
Well, other than realizing there are various tiers, I still don't understand down on the ground level who gets equipment and how much and how those decisions are made. In other words, does it go to a hospital? How do you decide what hospital or what amount? What about nursing homes? What about child care facilities? I mean, what about schools? I mean, there are some entities who, as I understand it, are getting some funding from other sources. It's just, to me, it's a big muddle. I just don't have in my head a clear understanding of how this works.
So on the ones that are getting the PPE, we said before, and there are also certain levels of PPE. There's non-medical grade. The non-medical grade stuff is the one that would go to your tier 3 and below. That's your emergency responder personnel, because they aren't required to have surgical grade. Now, how the determinations are made on what goes to the medical facilities and long-term care, and Dr. Dobbs, I don't want to get off in their lane, but the Mississippi Department of Health has worked very hard and diligent, and they actually have folks that call these facilities, and actually we're calling on a daily basis, and that has backed off somewhat, but they are calling and they are managing each of those facilities' burn rate at those facilities. What those facilities were getting on our deliveries were based on those discussions and those phone calls to those facilities, and it was based on the number of patients that they had, COVID patients, and if those facilities had critical care units, it would be based on also the type of patients they had, whether or not they were in a typical medical care, or if they were in emergent care, then the types of PPE would be different. But that's how that was determined. With regard to the latter portion of child care facilities, we have not been providing PPE for child care facilities, and we have not been providing PPE thus far. We providing PPE to schools, but HHS, federal HHS, has sent us masks, both adult and child masks, that have been distributed out to the Mississippi Department of Education, and I'm saying that without confirming it. We've received them, and I do believe the Mississippi Department of Education has gotten that and pushed those out, but that was not allocation of stuff that came out of what we have purchased. That came directly from the feds.
And what is the cost of, in relative terms, the cost of what you're buying today?
From where we started, I mean, as far as
Is compared to what a normal circumstance would be a year ago, we'll say.
gosh, I mean, I will tell you, I'm new to the PPE business. I couldn't even, I know a lot about it right now. I will tell you, I can tell you how much we have spent thus far, and we published that. It's let me find it here. On commodities and supplies, that would be your PPE overall, is about $123 million. And then you add in mission assignments such as those have been performed by the National Guard, disaster reservists, and other support in that. It's approximately $147 million thus far has been the price tag for that. PPE costs have come down. When we first started having to purchase PPE, it was basically black market. It was sometimes 5 and 6 times what the market would have been. If you'd have went into a Home Depot and bought a pack of 10 N95 masks prior to COVID, you would have paid probably somewhere around $24, which would have netted that down to around $2 a mask. We've seen prices as high as $8, $9, $10 per mask throughout this process. So I think we've done a really good job to mitigate that based on where the demand. Since the last 90 days, the PPE that we put out had been put out through RFP. We did not have to do that. We could have made direct purchase through an emergency, but in the sense of trying to be fair and keep prices down as low as we can, we've been utilizing a modified RFP process. So we've done what we could to keep the prices down and to be fair.
Dr. Dobbs, did you have anything to add to any of this?
I don't know if Jim wants to add something too. He can probably clarify some of the specific questions you have about our current distribution.
If you can make him come up to the podium, then
Yes, sir.
he can try to.
We'll do. But we do, early on especially did prioritize places that were taking care of sick COVID patients, hospitals, nursing homes. That's really where the big problems were. But I'll let Jim, who's kind of more familiar with the details. Jim Craig, thank you.
Thank you, Dr. Dobbs. Mr. Chairman, the prioritization for PPE was established back in March the 16th. So we got together and looked at other states and how they were prioritizing PPE and really brought a lot of those same concepts to the state of Mississippi. The Tier 1, the highest level of PPE for scarce resources, went to long-term care facilities with confirmed cases. So that was where we were seeing most of the deaths were obviously in our long-term care community. Wanted to make sure the infection control was as solid as it could be in that community. Second, to hospitals with the greatest number of confirmed cases. So at this point, in the beginning of the pandemic, There was not enough PPE to even go to every hospital. We had to prioritize to those hospitals that had the most cases, followed by EMS and first responders that were picking up those confirmed and suspected cases, and then healthcare workers that were working in long-term care facilities that may not be a long-term care employee, but your respiratory techs and your physical therapists and all that go into a long-term care community. So that was the tier that we started in, and I will say that we stayed in that tier for most of the pandemic, just trying to gather enough PPE to meet the requirements for just that group. There were a lot of other folks that needed PPE, wanted PPE. This was a time when physician practices were bringing PPE to the state to help us be able to fill the needs out in a local area. Since then, Director Michelle and the Guard and everybody that's been working really, really hard to get PPE in and out has worked well. As Director Michelle said, we call every day, every long-term care facility. We require them to report their inventory to us daily of how much PPE they have in hospital and in long-term care facility. And then we do some calculations based on the number of cases that they have and the number of suspected cases to ensure they have enough PPE to take care of confirmed cases in Mississippi. But we have not been providing a lot of PPE anywhere that is not dealing directly with a confirmed case at this point.
Does anyone have any questions regarding the PPE and the distribution and Senator Wiggins?
This is for Director Michelle. I want to go back to your the black market comment, because I've heard that. So do you know if those vendors were here in Mississippi and who was doing that? And the reason I ask, so that you understand, is that's the equivalent of price gouging, which is illegal in Mississippi. And unfortunately, we saw that in things such as hurricanes. So have you looked at that? Do you know what the status of that is?
Yes, sir. And I appreciate the question, and I'm going to be honest with you as I can. We were in a dire situation on the front end, and I mean that in all reality. We had been promised a number of times PPE that was on the dock in New Orleans, only to find out that someone had either gotten it or it was a scam. So there were several criteria that we used when we were looking at PPE, and it was unconventional. Overseas manufacturers, everything was coming from China. And that's sad in of itself, but that's the reality of it. Everything was coming from China that we needed. It was medical grade mask. The Chinese manufacturers required the money to be paid up front before they would take it off the dock. We were not going to assume that risk with using taxpayers' money and shipping it overseas or sending it overseas, because the state of Florida lost a lot of money doing that on the front end, trying to do the same thing we did. So when we went out and found vendors, you asked, were they from Mississippi? Some of them had Mississippi ties, but the majority on the front end were not from Mississippi. They were American brokers that were able to come up and front the cash to the Chinese manufacturers to be able to get the product. The vendors also had the ability to broker for the aircraft space that was going to be necessary to fly it overseas. And keep in mind that we were doing all of this and competing with the national stockpile, because they were getting the majority of the inventory and they were getting the majority of the airspace on planes. So if I got a million shipment of masks, I had to split it up to 100,000 to cram it in space on aircraft. So I had to have brokers that were familiar enough with how to get that done and to get it here. It took us about a month to find that. We didn't do background checks on these people.
Well, so who was charging the 90% markup or whatever?
Well, then let me go back and clarify that. I'm not saying that we paid that.
I understand.
What I'm saying is that those were some of the prices. And to a lot of credit for the vendors we got, that's what they were being charged overseas. So the markup in a lot of cases was not what I would consider to be gouging. And I will tell you that I've talked to my counterparts all over the southeast of the United States, and I mean, we were all right in the same boat with what we were paying. I was in a different position in Mississippi as well as a lot of the southern states, because if you remember the hot spots on the front end, it was New York, It was out in Washington and different. It moved around, and the national stockpile priorities were going to those places. We were getting stuff, but it was not enough to cover what the Mississippi Department of Health needed for that Tier 1.
Okay, so what you described then, and maybe Dr. Dobbs can answer this, seems like that's a problem, and so I'm looking at the future. How do we avoid getting in that situation again when something like that happens? If we have to, in other words, if we have to rely on China to service our supply lines, are we not setting ourselves up for this again?
If we don't have a state stockpile that is adequate to get us kicked off, then yes, we will. But we will not have that now because we have the stockpile. We'll keep at least a 60-day supply going into and out of this. And, you know, my recommendation is that the state maintain that so that we don't ever find ourselves in that position. Nobody could anticipate that this was going to be like this. It was bad, but through a team effort, we were able to get through it. Dr. Dobbs, you have anything?
And Director, just on that, my understanding is you have a warehouse y'all are looking at. Is that part of that plan?
That is part of the plan, and if I may, I'll just go ahead and trying to be transparent about that. The purpose of that warehouse is to make sure we have a place to put it, a place that does not leak, and a place that is climate controlled, because many of your constituents probably called and complained about some of the PPE that they were getting was moldy or anything like that. That was not anything that anybody did on purpose. It's just we were using what we had. We didn't know we were sending it out. So this warehouse will give the state of Mississippi the opportunity to have a stockpile to finish out this pandemic and address any future threats that we have of this nature. It'll also be a logistical supply node, and it'll also be a COOP site. So it'll have multiple functions.
The main thing I want to add is what a phenomenal job Director Michelle and his team have done. We had been in a lot worse shape if he hadn't really done everything and turned over every stone. And in addition to trying to find everything that can be found, we made some stuff like with some local manufacturers with maybe not medical grade masks, but certainly, you know, a step down, but certainly very useful. And also for gowns, we're purchasing gowns now, I think, that are manufactured in Mississippi. So trying to expand the pool of resources locally where we can, but some of the stuff, N95s and things, unless you had like a FDA approved manufacturer, that's going to be a little bit tougher to kind of achieve locally. Thanks, sir.
I think I need to get those of you off to your TV show. So thank you for coming. Appreciate it. I'm told that Wendy Bailey is here at the Department of Mental Health. Is this true? Is this true? You were less burdened than some of the folks, but how do things seem to be going with your piece of this?
Let's see. It's going well. We have, as you know, 12 program locations across the state that provide 24-hour, 7-day-a-week care to individuals who have intellectual and developmental disabilities, serious mental illness, and substance use disorders. So we were absolutely impacted with the need of PPE, as you earlier addressed, and we thank Dr. Dobbs and his team at the Department of Health who have been wonderful partners throughout this for our agency. We're starting to see decrease in the number of cases among our clients and our patients, and decreases in the number of cases among our staff. So it's trending down kind of as the state numbers are trending down. The handout that you have is in regards to Section 5 of House Bill 1782. And the information that I wanted to share was there was $1.4 million that was appropriated to the Department of Mental Health, specifically to be provided in equal amounts to the 14 community mental health centers. So each community mental health center was awarded $100,000 of this funding for expenditures related to COVID in 4 different areas, which is there on your handout. I also provided on the handout a breakdown of how those expenditures were allocated. You can see a portion was allocated for mental health services or payroll expenses at the community mental health centers to provide mental health services. And then there was a portion allocated for the purchase of PPE supplies, and there was a portion allocated for electronic equipment and upgrades for telehealth. The second page actually shows you the breakdown by community mental health center. So as I mentioned, it was distributed in equal portions. So each community mental health center was awarded $100,000. All of the money has been awarded, and you can see the claim submissions for the month of July and the claim submissions for the month of August. So to date, there's been $469,761 expended where we have actually received claim submissions from the community mental health centers, and $930,238 outstanding. We have reached out to each one of the community mental health centers, and all of them do expect to expend their full $100,000 by the end of December. As you can see, one already has. This was the document, Senator Bryan, that I sent you last week, but even as of yesterday, we got some additional cash requests coming in, so it changes weekly, and we provide that weekly update to the Legislative Budget Office.
But there's $1.4 million, which is $100,000 for each community mental health center.
Yes.
And it's your understanding that each of the community mental health centers is going to be able to spend $100,000. The fact that some have already spent it and others haven't sent in is just the variation as you go from place to place about what they're doing with it and how the level of expenditure and everything. But you tell me that you've talked to all of them and they're all going to be able to spend the $100,000.
Yes, sir. Some have asked if there's additional funding that they could use that as well. It's been for a variety of things, PPE, sanitizing equipment, but a lot of telehealth as well, which has been very beneficial, especially as individuals, if they can stay home and receive their services, that's important. So the telehealth component has been very useful.
Any questions about mental health? Senator Hobson.
Thank you, Mr. Chairman, and thank you, Wendy. You know, when I look at the regions and what they've spent, and a few of these, you know, start with Region 4 that's only spent $973, you know, what is going to change between now and the end of the year that would make them spend, you know, over $99,000 that they haven't had a need to spend thus far?
So Region 4, we asked each community mental health center to send in a budget narrative of how they expected to utilize those fundings. And Region 4 has sanitizing equipment, sanitizing supplies, but then also telephone and internet upgrades for telehealth services. It's very possible that they have purchased that and they have just not sent us the claim submission yet.
Thank you, Mr. Chairman.
Anyone else? Thank you.
Thank you.
Dr. Rankins? There were funds sent to the institutions of higher learning, and Dr. Rankins, I think it's fair to say there have been some difficulty with this. We were going to send some money to the physician scholarship, rural scholars, and there was concern about it complying with the federal regulations. So can you work us through these two problems and where we stand now?
Thank you, Mr. Chairman, and thank you to the committee for your time. I'll start with the funds that were allocated to the Office of Physician Workforce to support expanding residency programs. The amount was $4.4 million, and to comply with the language in the bill, the medical center worked with 5 coordinating hospitals who submitted contracts to the board office outlining how they would expend the funds. And as a part of the board's contract review process, we rely on the Attorney General's office, who serves as our legal counsel. Upon their initial review, they raised concerns with the contracts, particularly alignment with the language provided by the Treasury on using CARES funds. In the specific concern was the provision that the funds must be substantially dedicated to mitigating or responding to COVID-19. That was the sticking point. So we asked the hospitals to provide more detailed budgets with specific budget narratives outlining how they would use the funds in hopes that that would satisfy the concerns in the AG's office. We're at the point now where we think that there's sufficient language in the contracts where we will get approval from the AG's office that they will certify that the contracts are applicable to federal and state law. 2 of the 5 hospitals have responded that they're okay with the adjusted language in the contracts. 2, their lawyers are looking at them now, and we anticipate a response in the next couple of days. And one of the hospitals has not responded back to us. The last time our board met, we talked about this issue, and the board is prepared to have a special call meeting and take these contracts up, provided we get an affirmative memo from the AG's office. I will say that even if the contracts are approved based on our conversations with the medical center, we do believe that the hospitals are going to have a difficult time trying to tie expenses associated with the residency program directly to COVID-19. So at some point in the future, when there's time for those expenses to be reimbursed, we believe that the hospitals are going to have some challenges, quite frankly, Senator Bryan. The other part of the 1782 related to our system was the Rural Physician Scholarship Fund, which 1782 provided $1.8 million to this program to pay for medical students to serve the rural area of the state. The problem here is scholarships to medical students do not appear to meet the requirements on the federal side based on the guidance that the expense must be substantially dedicated to mitigating or responding to COVID-19. We've been advised by the medical center that first and second year medical students are in preclinical training and have minimal interaction with patients. Now, third and fourth year medical students are on a rotation schedule in various disciplines that are designated to meet their academic accreditation requirements, and those rotations likely will not be substantially dedicated to working directly with COVID-19 patients. So at this point, Senator, the total amount allocated to the medical center is about $6.2 million, and those funds have not been expended because of these issues that I outlined here. And the specific problem with the residency program, I think, is detailed in the handout that you have before you.
Well, let me work through this, and maybe I'm more easily understood without this. I don't know. We have a Rural Scholars Program, which is based on the notion that if you want people to practice medicine in rural Mississippi, your best shot is finding someone who actually lives in rural Mississippi and convincing that individual to become a doctor. You're not going to do a very good job going to Harvard Medical School and trying to recruit graduates from Harvard to come to rural Mississippi. It, in my opinion, is a program that's worked extremely well, And it's not perfect, but it's probably the best shot at actually getting doctors to live and practice in rural Mississippi. It's a fine program. One of the problems that COVID is bringing to light is the need for healthcare generally, and specifically healthcare in rural Mississippi and where there are populations that don't have access to doctors and all of that. But the issue that's before us is, under the federal regs, how can we link up the expenditures in the Rural Scholars Program for or with the COVID crisis? And all the common sense of it is, well, yeah, this is going to help. There are people who are trying to make sure that this doesn't run afoul of federal regs. So my understanding is what happened procedurally is this having been dumped in IHL's lap, IHL's attorneys and everybody got cold feet and said, we're not sure we can promise that that's going to work. And as I understand it, the current proposal is, more or less, we'll bump this problem to the Rural Scholars Program. And we'll sign a contract with the Rural Scholars Program and all of that, but then that's going to then bounce the very same difficulties that we had down to the program itself. Am I is that close, or am I?
That's pretty close, Senator.
For government work, as they say. And the same proposition with residency programs, which is a very fine thing. I sure do wish I could figure out some way to take credit for this. But the notion is that when doctors go somewhere for their residency, sometimes they get snatched up and stay there. So there are hospitals around the state which are establishing residency programs. They're not rural hospitals in the most extreme sense of the word, but they're hospitals in Mississippi that have residency programs, which may get the doctors out into some of the more rural areas. And again, this to me seems a very common sense way of having doctors who are now doing their residency stay in Mississippi longer. Perhaps find a spouse. That always helps. Find a spouse who's local, and that'll work. But the problem is the same, and these 5 hospitals then would be on the, you can contract with them, but then they're going to have to go through the same calculus that gave IHL cold feet, which is, can we certify that the additional funds for the residency programs are attributable to COVID within the meaning of whatever the federal legislation is. And that's where that stands.
That's where it sits, Senator. And
questions? Senator Harkins.
Thank you, Mr. Chairman. This 1.8 million, I know you said there are some problems with it, but is that that's going to be one payment of 1.8 million, and what would happen to the students that you put into the Rural Scholarship Fund? Is that what it would be for adding students to the program?
it would be to expand the current program.
Okay, so
it would be
1.8 million, how many students would that cover?
I'm not sure. We've got somebody from the medical center here.
Would it be 1.8 million for 4 years for an expansion of those students, or 1.8 million for this year, and then we're going to have to come up with 1.8 million to cover that expanded?
Well, if I see where you're going, yes, you would need those funds in multiple years because they're not going to be in a residency program just 1 year.
Okay. So that's what I guess my question was, is if the 1.8 million was meant to cover 4 years of medical school for a certain number, or if 1.8 million was to cover as many students as you could get into 1 year of medical school. I guess.
But I do want to point out that based on the federal guidelines, and the state guidelines, those funds have to be expended by the end of the calendar year.
Okay.
So you couldn't carry them over to.
Couldn't prepay? Thank you.
Senator Hobson?
Thank you, Mr. Chairman. Commissioner, you mentioned that the AG's office is looking at getting you some opinion on this because of the time constraints we're dealing with here. Can you give me an idea? Have they given you a ballpark as to when they should have an opinion?
Well, we thought we'd have it by now. I anticipate it could be, before close of business today, but I don't anticipate it moving past this week. Based on the last verbal conversation we had, they're pretty close.
Okay. Thank you. Thank you, Dr. Rankins. Thank you, Mr. Chairman.
If there are no other questions for Dr. Rankin, at this point, I thought we would take a quick break and we would come back at 2:30, which is approximately 10 minutes from now. This will allow the MDA people to get set up for their presentation and let us all have a quick break. And so we'll stand in recess until 2:30. Thank you for coming over.
Kevin, how's Medicaid?
Thank you. Good luck running the colleges.
Commissioner Kane, Medicaid.
I'm process of getting it cleaned up so I can set. I'm told there's a barber shop where I can go park it and someone will eventually come by.
Somebody said Commissioner Kane is out talking about that was something that I tried to do. Well, hell, you're on here called me today.
Well, this is the last one. Unless
I said, that was something that I tried to, when we did the tech bill, because other states are doing it, $dollars or something. If you leave, because right now they go in.
Yeah, let me catch Kim.
Are taken off of Medicaid, and so that's what. So the state has to bear the burden. They're on Medicaid, and they stay on it.
yeah, that's exactly right.
And Medicaid kicks in. So when we tried to do it, Bill torpedoed it. Told here today, and I said, see, that's the freaking problem. Is that we tried to do it, and the governor who runs MDOC because of politics torpedoed it, and now the current commissioner's going around to try to get it done. So it's Good. Yeah, that is what happens. And also, we were doing that, I actually had a supervisors association. So that, because here's what happens. This is how you where are they having that at? What town? The counties in the Wolford building, and Medicaid covers it, and that's taken in out of the state Medicaid dollars. Have somebody there. Now, does that mean what's the logistics? So in essence, what it is, and by the way, this is something that's supported by conservative groups, believe it or not, because actually there is only 700 people when they go off of Medicaid, and there's a ramp up, and they get out, and they know, so it's a better use of government funds if you're going to. So there's groups out there that support this, and so state, I think like even Texas has done. Yes, it will raise the cost of Medicare, but it will reduce the cost to the Department of Corrections. And if you know one of their number one, you get the match. You get the match. I'll go look for my paperwork. Also, now there's. She works for Johnson & Johnson. Now, as you can imagine, there's some incentive for the lobbyists, but she actually was very good at helping me understand this. So I did my research. She put a lot together, and they pushed it back then. Actually, Burton, she was working with Burton anyway. And in the original bill that I filed on the tech, it had that in there. And we were going through, and Phil, I even think it passed the Senate. When we got to conference, Phil was going around trying to keep it, because he's like, oh, they're going to say we're covering prisoners, which. So, in terms of, but the question that, I don't remember what the number, but let's just, maybe 80 million, 100 million, whatever the cost to Department of Corrections is. That is, that we're having to pay out of the regular, back to your point. Yes, it will be covered by Medicaid, and that frees up budget items to use for other MBS systems. Even though I'm actually doing the MBS budget, I go look, we allocate that's why we pushed the geriatric role in 21-23, because they want these, they need these people. It's in the paper. They need these people out because it's costing. I get it. It's this public safety person. So I did a lot. I said, okay, because I was a little nervous, and they said, no, look, Bryce, conservative states are doing this because what you're doing is, the law is when they go in with benefits, or even if they were on it, stop. Okay, so in the state, or let's say they're in the county, and the guy has a diabetes thing and is taken to Singing River Hospital, the county gets the bill. Okay, they have to pay it out of their budget. If they were automatically covered under Medicaid, they know the Medicaid will pay. That's right. That's smart. And so I heard that's what they said Commissioner Payne was talking about. And knowing how I think he seems to, and I want to try to meet with him on some stuff, but I think it would be important to, since we're doing the tech, to kind of look at that. And
Approacheth. The time is nigh. We've been making pretty good progress so far, and so I understand that MDA has a presentation that involves these little electric screens. So if you're ready, we'll let that go. I will say once again that this is not something that MDA does every day. Nobody at the Mississippi Development Authority went to work there for the purpose of dealing with a pandemic. So they're like everybody else. They're in the middle of this and doing the best they can with what they've got. So thank you, and just go right ahead.
Thank you, Chairman. Thank you, Vice Chairman Polk, Senator Wiggins, Senator DeBar. We should have given you a handout, or maybe a few handouts. So I'm going to start with the cover, which is just a front and back titled Update on Programs enacted by House Bill 1782. And this comes out of Section 2 of the House Bill. After y'all passed the legislation, the governor signed it, we went to work on understanding what our responsibilities would be. And as we read through the bill, we determined that that would require two programs because the way they're described and the way the money would flow was distinctly different in our mind. So the first we entitled the Healthcare Providers PPE and Testing Reimbursement Program. And that fund is about $19,057,000. The second is the Community Foundations Program, grant program, and that represents $11 million. The reason those programs are different is one is a pure reimbursement program, and we've set up a process by which those eligible applicants make a request for a reimbursement, and we provide that reimbursement. The Community Foundations, which is split into two grants, one is $4 million that would be granted ultimately to nonprofits, and then the other is $4 million that would be granted to food pantries. That money is advanced to those 7 community foundations listed in the bill. And so as soon as we get grant agreements with those entities, we will advance that $11 million to them. There's also the North Mississippi Education Consortium that we will, I guess we've already written that check for $3 million. So they have their funds already. So as we do with any program that's established by legislation, we normally enact rules. We promulgate rules, and so the normal process to do that is 60 days. You adopt them, they go out on public comment, we receive public comments, and then we make maybe changes or we make final adoption. We've been adopting these under temporary rules or emergency rule status. And so we believe strongly that a few things. One, we wanted to deliver these programs with speed, but also compliance. And so we think answering all the questions up front and making that transparent is the best way to do that. So for each of these two programs, we adopted rules. They were posted to our website with the law so that everybody could see that. We had, I don't know, numerous dozens of calls, Zoom calls, and other, trying to collaborate with different associations and with the community foundations, trying to formulate these rules where everybody understood it moving forward. We've hired 2 contractors. We hired an accounting firm which actually receives the reimbursements or the requests for reimbursements, and they actually account for and make sure the claims are eligible before they get paid. That's Harper Raines Knight, CPA company out of Ridgeland. And then we also hired a IT company, and we'll talk a little bit about the reason we hired them. But because the numbers of eligible applicants is in the thousands because of the Healthcare Providers Program, we needed to be able to deal with a lot of volume, a lot of applicants at one time, and so we established a website, and we'll kind of do a quick demonstration of that before we end. If you flip the page, we'll give you just some quick snapshot of some statistics. This is as of, I think, yesterday, close of business. We had 474 providers registered. Now, a healthcare provider can be an individual eligible entity like a nursing home, or it can be a practice group that houses up to 25 independent physicians or independent dentists. So 474 registered providers, 181 of those providers have already submitted claims. There's a breakout table in there that gives you a breakout by each of the individual eligible applicants. We've approved about 57 reimbursements for about $300,000, but that number changes daily, and that gets reported daily on Transparency's website. So if you ever have a question about the progress of the program, you'll see it about 24 hours or 48 hours delayed in terms of how much money has been expended. Of the Community Foundation's COVID-19 program, as of today, we've got grant agreements with all 8 community foundations. So we'll be prepared to process their checks to advance them that $11 million by the end of this week or early next week. And again, just as a note, there's a link to the Transparency Mississippi webpage that tracks all the CARES Act funds. Any questions before I just do a quick walkthrough of the website?
Why don't you walk through while you're going, and then we'll come back and have questions.
Okay. So Harrison, this is our landing page. So if you go to Mississippi.org, MDA's website, there's a banner that will direct you to the Healthcare Providers and Testing Reimbursement Program. If you go to this site, if you'll scroll down, Harrison, you can see some of the information on tabs, the House bill itself. We've got frequently asked questions, the rules that we talked about that give definitions and kind of specific direction and instructions about how the program will be run. And then when you're ready for that, or I should mention also there's a 1-800 number, and this number goes to Harper Raines Knight. So if you have questions about your reimbursement or the program or an application, you can call this number directly to the accounting firm and they'll help you walk through it. So if you click Apply for the Healthcare Providers, PPE and Testing, you'll go to another link which basically asks you for a login and a password because this information needs to be secure. We have a 2-factor authentication to protect that information where people can't just access it without having some direct, specific information tied to their application. So this is just an example of a few tests, what the pages look like. So you would go in there, you would enter your basic information about being a provider, identify who you are. If you want to click through and add a provider or show. So we're going to ask you first, tell us which one of these eligible applicants you are. Are you a nursing home? Are you an independent physician? Are you an optometrist? So you'll select one of those, in this case, independent dentist. Then we're going to ask you, are you with a practice group? Or are you applying by yourself just as an independent dentist? We'll ask you what your license number is. All the licensure numbers we have, the universe of eligible applicants is defined by the law. So we have all those spreadsheets from the Medical Licensure Board, from Department of Health. So we know if you're eligible or not, but you have to identify yourself, and we check those to make sure that you are an eligible applicant. So we'll ask, who is the authorized representative? That could be an office staff person from a medical practice that may be entering the application. We'll get their contact information, an email address, mailing address. This is all just basic information for the application. We tried to design it where it's simple and it flows and it's not very cumbersome. Once you enter your basic information, I think you'll click Next. You have to fill in these fields or it won't let you go to the next field, so it makes sure that the application's complete. So these are the terms of the grant agreement. So ultimately, each of these eligible applicants has to agree to the terms of the grant, that they know what they're signing up for, what's eligible, what will be the expectations. And so we're calling this the grant agreement that they'll sign online. So they just do that by providing their name and a date. So it'll ask you again, are you sure information is right? You do the grant agreement, so it puts you in the system. So now we have a grant agreement. We have an official grant agreement with the eligible entity. We know who they are. Now they can begin to request reimbursement. So the reimbursements go all the way back from March the 1st, meaning they may have accumulated several eligible expenses up to this point. They can submit all that up to the current date by adding a reimbursement. So they're going to get the reimbursement form, which is a fillable Excel file, which basically it only gives you a few options. It's going to ask you which of the eligible expenses are you asking for reimbursement. Is it PPE, is it testing, or is it screening? And then give us the amount that you're requesting. They'll sign that. And then we need to have the documentation. So you filled out the form that said, I've got $2,000 of PPE expenses. And then we're going to ask you upload that document and upload the receipt or the invoice that supports that request. So you click the upload button, you'll upload those documents. You can drag and drop into this screen here. So as soon as you do that, it goes immediately to our accounting firm. So in real time, as you're uploading your reimbursements and you're doing your grant agreements, it goes to our reviewers. They begin the review process. Once they've said approved, it comes back to us. We send it to DFA, and then the next day it gets a check cut, and the next day it shows up on transparency. That's basically the process.
Okay. I thought I would work through sort of the various pots of money one at a time, if it's at a time that's proper to do that. I mean, this is a good point to do that.
Yes, sir.
Okay. As far as the ambulatory surgical centers, they would go through this process that you just outlined. Is that correct?
Yes, they would.
And so they fill out the form. So have we got to the point of actually sending money to any of them yet? I mean, where are we are there people who've gotten checks, or how far along are we?
Yeah, as of yesterday, there were 57 reimbursement requests that had been approved for payment, and that equals $300,000.
Okay, so it's up and running.
Yes, sir.
And so far as you know, there's no problem with the ambulatory surgical facility. Nobody's calling up and saying this doesn't work, or?
We've not heard of any technology deficiency. I mean, there's questions about the application, or there may be a question about what are you asking me for? What's sufficient? Is an invoice sufficient? Is a receipt sufficient? All those things are laid out in the rules and the FAQs. So I mean, we remind people about what we've already told them, but we don't think there's any deficiencies.
Assisted living facilities, Alzheimer, dementia units, intellectual disabilities. Any issues with those?
No, sir.
Does it appear, or do you know that the money's going to, so far as you can tell, both be adequate and be spent? I mean, I don't know that you know. I'm just trying to sort of flesh out where we are at this point.
Yeah, I think the challenge that exists is going to be time. I think for those eligible entities that probably for the last several months already have invoices or receipts that they can submit us today and get reimbursed for that. But the program has to be completed by the end of the year, and so they've got 90 days to basically submit what they're going to submit to us. So you're not asking for a number, you're just asking me.
No, I'm just saying, are you now in a position of saying that and these people have a particular problem? Because there is the issue with ground ambulances who say they do have a problem and that their needs are greater than the technical language of the bill, which is to purchase protective equipment and testing and those things, that they have eligible expenses, but not necessarily for those. Has that worked its way to you?
Yes, okay, I understand where you're going. Yes, we have, as we've communicated with some of these eligible entities and as we've adopted rules and got into the program itself, yeah, that is one instance where there was a question about whether, I think at least one of the questions was, is hand sanitizer an eligible expense? Is that PPE? And we believe the answer is no, because the CDC says it's not. And so as we develop these rules and we try to be consistent across the state, really, we had to determine what is PPE. And so what we decided PPE was what the Center for Disease Control said PPE was, which at the time, or I guess currently, does not include hand sanitizer.
But this particular problem is generated by the text of the state appropriation bill. This is not a problem with federal regs.
That's correct.
In other words, the federal regs would let you buy hand sanitizer, to use that example.
Yes, it would, yeah. In fact, the community foundations, which their eligible expenses is the broadest. It's anything eligible under the CARES Act is eligible for reimbursement under the community foundations program. But specifically for the healthcare providers program, you're right, the law specifically says PPE.
Well, just since we're making a list of issues, there's an issue with the ground ambulances who have a problem because, not that they don't have eligible expenses, but because of the language of the appropriation bill. What about nursing homes?
I've not been made aware of any issues with nursing homes.
Mississippi Organ Recovery Agency?
No.
The dentists, do we have issues with dentists? Are they?
Not that I'm aware of. The issue that we've tried to stress with independent physicians in private practice applicants is they potentially receive payroll protection program money. They could have received a back to business grant. They could have received other CARES Act money. And that if they did, we have to be sure that they're not duplicating those reimbursement requests for this program.
But your back to business grant, isn't that just money you use to operate on?
No. It could be. Payroll is ineligible under back to business, mortgage interest, but also COVID-related expenses. So you could submit to us a COVID-related expense like PPE and get reimbursed through the back to business program.
You're supposed to be paying your help with that money.
Sir?
You're supposed to be paying your help with that money. But anyway, but money's flowing to the dentist, money's flowing to the doctors, and they're not all calling and saying this is just not workable.
No, sir. We've not heard that.
Community foundations. This is $4 million with the idea that the community foundations themselves would identify nonprofits in their areas and that they would make grants to nonprofits to help basically poor people who had lost jobs, had all the economic losses, who having trouble getting food, utility bills, also purchasing the ever-present PPE and all of that. And so how is that going? I know there have been issues with contracts between you and the community foundations and all of that. So where does that stand?
Yeah. It took us a little longer than I I hoped it would, to get grant agreements with the community foundations, but part of that was just the negotiation. One, they wanted a document that covered them, their risk, because they didn't want to issue grants that we would later try to claw back in some way. So they wanted the grant agreement to be very specific in some cases and make sure that they were doing the right things in compliance with the Federal CARES Act. And we also wanted that. I thought we would have that done by mid-August. It took us to the end of August to do that. And so we have all the grant agreements signed. Well, they're signed, but we've received them all. They'll be signed as of today or tomorrow, which will allow us to release that $8 million to each of those community foundations. And at that point, really the burden is on them to run their program. Now, we'll have to monitor them once a month. They'll send a report to us, and our accounting firm will help monitor to make sure that they are complying with the CARES Act and with the grant agreement. But we believe that those discussions were fruitful and helpful, and we think there's clear guidance and understanding about who's eligible and how they'll run the program.
Well, then when the money gets to the community foundations and they start trying to send it to the nonprofits there on the ground out in the sticks,
Yes.
Mechanically, how is that going to work? And with the community foundations now in a situation where they've got such restrictions on what they can do with the money that it's limited in what they can do with the folks on the ground?
My understanding is they also have developed a web portal so that eligible nonprofits would apply to them through this web portal. In the rules that we drafted, it goes line by line for a couple of pages of what eligible expenses are, and it's pulled straight from the Treasury rules and from the CARES Act. So it is as broad a list as there can be for COVID-related expenses, and we've outlined those in the rules. And so the community foundations have those. The nonprofits that are applying will know exactly what is an eligible expense, and they should be able to process those, I'm hoping, very quickly.
Well, I don't have it here in front of me, but there's sort of a catch-all that says something along the lines of, and these are examples, but they're not exhaustive, sort of like the Ninth Amendment. Some of us have a broader view of the Ninth Amendment than others, and so I'm wondering, because there's a list, and or people getting cold feet about doing anything that's not on the list.
Well, they should have cold feet if it's not on the list, because if it's not on the list, it shouldn't be reimbursed. But the list is pretty expansive.
But the list itself that I saw, and again, I don't have this in front of me, says that these are only examples and the list is not exhaustive, or words to that effect. And I don't have that in front of me.
I don't think people are getting cold feet. I think we've written a good document. We've given good guidance. I think there's a clear and broad list of eligible activities that I think they'll be able to deploy this money with. I don't think they're going to get cold feet.
Then there's money for food pantries.
Yes. That one was a little trickier for us. One, back to your point, we don't normally deal with food pantries, and who is a food pantry? Who regulates food pantries? And so we had to define that early on. We had a lot of discussion about, well, who is an eligible food pantry? But we did define it. We do believe that the community foundations are comfortable with the way we defined it, and they had a lot of input to that. And so we think they'll also be successful being able to provide sub-grants to food pantries.
Do you think there are enough food pantries out there to use up the $4 million?
You know, I just don't know enough about that group of entities to tell you. I mean, it seems like my instincts say no, we don't have that many food pantries. But given the pandemic, there were a lot of churches, a lot of organizations that became food pantries in the last 6 months, and they would be eligible. So maybe in a traditional sense there's not, but in a program sense, as it relates to these eligible food pantries, there might be.
I would think there would be plenty of nonprofits, but do you know if the community foundations said they've think there's a problem with spending that amount of money?
You know, no, we've not heard that. I think I want to say the genius of the bill is, and I don't
the
want
genius of the bill.
but
I'm
but y'all
not
broke it up
responsible for any shortcomings. The shortcomings are someone else's problem. I
Yes.
don't know who, but I'll figure out who that is.
Yes, I think a great aspect
If
of
there's
the bill.
anything you like about it, I did that. If there are
Yes,
any
sir.
problems, they're someone else's fault.
Yes. Well, I do like this about it, which is the money is proportionally given to the community foundations on population. So a Gulf Coast Community Foundation is familiar with their nonprofits, and they have a proportional amount of funds likely to meet the need of those nonprofits. Same thing with the Create Foundation in Northeast. And if it's a smaller geographic area, smaller population, they got less money, so they won't have to meet the same needs as, say, Hattiesburg or Tupelo or the Gulf Coast.
The North Mississippi Educational Consortium for daycare.
Yes.
I have checked with them, and they have managed to get on their internets a connection to like 900 daycare centers. I have asked repeatedly, and I've been told repeatedly, notwithstanding the name of this operation, this is a statewide operation and the money's being spent statewide. I've not heard any complaint about that. I am told that the daycare people are ready to use this money, and they're using it to purchase PPE, but there is a buying group, for lack of a better term, that has negotiated a contract for the purchase of PPE by daycares. So if it's sort of like buying off the state bid thingamajig, if that it worked properly, but some mass purchasing group has already negotiated the discount for you. So you, as an individual child care center, order from this list. But I've also been informed that it would be relatively easy, just as the hospitals can send a check for an additional 2.5%, that sending additional money to daycare centers would be a relatively simple thing to do. So I mentioned that to say that one of the options that we have in this bill is to say if money's not spent by December the 1st, that it's dumped into this other program. And I think if the consortium got an extra $250,000, just by way of example, on December 1st, they would have a mighty good shot at getting that used up by their existing group before December 30th. All of those figures and dates are arbitrary, but that's a possibility. That appears to be all that you're responsible for. So are there questions for the Mississippi Development Authority about any of their programs? Senator Wiggins.
Thank you, Jamie. So if I understand your numbers right, looking at the healthcare providers PPE and testing reimbursement program, so far a $301,000 has been awarded, and there's $19 million in total funds. I have a hard time thinking we're going to expend all those that money. Is that assessment correct?
I think I agree about difficult to spend all the money because of the timeline.
Right.
What I don't know is, and what we're trying to get our arms around is are we going to be $1 million short? Are we going to be $5 million short?
Short,
I mean, of spending less than $19 million.
Oh.
I mean, I think these physician
well, we've not
groups-
even spent $1 million, and it's been 5 months.
Well, but we
and-
just opened the program September the 2nd.
Okay,
So they've only been able to register, sign a grant agreement, submit reimbursement the last 2.5 weeks, or I guess 3 weeks now.
so, and you've helped me understand that. So this grant program is this reimbursing, as y'all see it, reimbursing for the expenses they put out for PPEs and all, let's just say earlier in the year?
It can go all the way back to March the 1st.
Okay.
So anything they incurred up until this date, and then and moving forward through December.
But if the trends hold, the need for PPE is going down. And we would hope that would be the case. So it would be the reimbursement for what was spent back to March. Right?
Yes.
Okay. And that's what you're saying. You don't know whether that's going to come up. We don't think we'll spend all of it, but whether that's going to be $1 million left in the bank or $5 million, we don't know yet because people are still applying for the funds.
They just started applying, that's right. I think
Okay.
by mid-October, we'll have a much better handle on what the burn rate looks like.
Okay. Thank you.
Anyone else? Well, I'm going to summarize. And sort of following up on what Senator Wiggins was asking, I believe it's likely that here, yonder, and there, we're going to have funds left over for various reasons. I don't know how much money. You know, I'm still in a world where $100,000 is an awful lot of money. You know, so one thing that we might think about looking toward the October session is, do we wish to have some sort of catch-all for what happens to unspent money? Within that, I have the following things written down on my little book. There are the hospitals, the psychiatric hospitals, the Methodist Rehab, and others who did not participate in the $80 million. Do we wish to send funds to them, and if so, how much? Secondly, there are issues with the physician workforce program and the rural scholarship program. We're talking here about $6 million. Now, there is this fix, which I mentioned just as a theoretical fix. I'm not endorsing this. I'm mentioning this now so people can think through it. We can send money to the University of Mississippi Medical Center, and we can send money to these 5 hospitals. They've got all sorts of eligible expenditures for which they could be reimbursed. We would not be sending them the money specifically for those programs, but of course, money is a fungible good. In my old age, papers stick together. It's just not good. There's the issue with broader language for ground ambulances. There is the question of whether there are or are not remaining issues with the money going to community foundations for food pantries and for nonprofits. But there also is the issue of potential leftover funds there. And those are the things I have written down on my little piece of paper. So it would be my hope that there would be some discussions within the next week or so, and it would be my preference that we would have a bill to amend the appropriation bill to take into account these issues. I didn't mention it, but there's also the question of the $6 million for the program for the community mental health centers, and the governor's attempted veto, and where that stands on the timeline. One possibility is to have a provision that says if the Supreme Court hasn't ruled by December the 10th, or pick a date, then you would do something else with the money. Those are the issues that I have related to this. Does anybody have anything? Thank you.
Thank you.
Since we're all here, I will report on another matter, and that is the czar or czarina of mental health, or perhaps I should say the Czar X of mental health. It's hard to keep up. We have a state personnel system. The system was designed by Talmudic scholars on LSD. So there's that. Secondly, the general legislation which we passed was put together in its final form late in the process, and so it's imperfect. Once again, I'm responsible for everything you like. If there's anything wrong, it's someone else's fault, but it's just, there was language in the bill that made it difficult to hire this person. The good news is that DFA, which is to say Liz Welch, is supposed to hire an individual, and she has located an individual she wishes to employ. And the individual is interested in this job, and she has described this individual as perfect. So, let's solve that problem. But there's ongoing discussions among DFA, mental health, the personnel board, and honestly, they're all just trying to get this individual hired and deal with the personnel system and deal with the language in the bill we passed. I have every reason to believe that this will be resolved by Halloween and that the individual will be employed by Halloween. I wish this had all taken place sooner. I wish it had not created the problems we have. But at the end of the day, the problems that we have with our mental health system, which have led to the litigation and all of that, are overwhelming, and it's a lot more important to get it done right than to get it done quickly. Again, this is yet another, to be frank about it, impact of the pandemic. It's just having all these effects. But that's where that stands. And I thought I would make that report. I'm also informed that at the October session, Shot Lady will be here. And so I just want you to warn you that if you need to be absent from school that day, or you need to get a note from home or something, Shot Lady's coming. So that looms. Anything else? Anything else? Thank you for coming. I think it was productive. It's my intention that we will have the hearings later this year that we've been discussing to look at scope of practice and all those many issues. But thank you for coming today.